Welcome back to LaserChat, where laser experts share their tactics and techniques that prove that there's many more ways to treat most conditions, and certainly every patient. Today's experts, Dr. Jason Pozner and Patrick Bitter, share their secrets to success.
So Patrick, let's go to the first case.
All right.
Okay, so this is a 62-year-old woman who is looking for some facial rejuvenation, but she doesn't have a lot of downtime. Okay, she has a little bit of downtime, but not a ton. So if she came into your office in California, what would you do?
Well, this woman has extensive sun damage in her skin. She already has early precancerous changes and quite extensively. So her face has a number of actinic keratoses on it. So the procedure that I typically would recommend is going to leave those actinic, which is the broadband light treatment, is going to leave behind the actinic keratoses. And it's important to get those cleared up.
So you would just do BBL on this patient?
No. If I only
take me through your protocol. If she walks in your office, how many treatments? What are you going to do the first time?
So if you only did broadband light, her skin would look clearer and her skin would be better. But what would be left behind would be a number of actinic keratoses. And she has them extensively in the cheek area, around the eyebrow area. And those need to be treated and improved. So broadband light by itself won't clear those. She needs more than that.
So what would you do?
So I would offer one of two options. I would either use the erbium YAG and do a full field resurfacing in combination with broadband light, and that would have the greatest amount of downtime, or I would do the halo combined with the broadband light. And I would do the BBL first, then follow that immediately with halo. She needs what is a more aggressive halo treatment, not a mild halo treatment, but a more aggressive one.
So if you did full field, okay, I mean, look at her peri-oral lines. If you did full field, I'd probably get the best result on her peri-oral lines. How deep would you go on the rest of the face if you were looking to do a full field resurfacing along with your BBL?
Well, with the halo, to clear those actinic keratoses, the erbium YAG is where you need to go deeper with that. So at least 50 microns. I typically will do about 50 microns for a full face with the erbium YAG, and the 1470 I like 325 because it picks up pigment really well. It's the erbium that's going to clear the actinic keratoses. I have a special technique with the halo where I'll go over identifiable actinic keratoses and even do them to 100% at 100 microns.
We kind of do that. If there's a bad spot on the face, we tend to go over and over it. So I'll tell you what we did in this particular case. This is a little different than I would probably do in my practice because this was one of the original halo study cases that we did to get FDA approval. So this patient just got halo at a fairly aggressive setting. So if you look at the settings, this was 425 at 45% along with 50 microns of ablation at 30%. So a fairly aggressive setting in two treatments. Look, the proof of the pudding's in the eating. This patient got a great result. And you can see that from the UV photos, there's definitely a reduction in UV damage. A lot of the reds are gone and the color's fantastic. But if she came into my practice and I had this Sciton platform and you said, what technology would I use on the platform? I would say, let's resurface around her mouth because she's got a lot of wrinkles around her mouth. I'd use BBL on her cheeks, and I'd probably combine halo as well with BBL. So I'd use the full strength of the platform to use different parts of it to treat different things on the face. And I would probably get a great result in one treatment rather than having two treatments, but she'd have more downtime.
So her after result is after two treatments then?
That's after two treatments.
Okay, with the same halo parameters.
With the same halo parameters, yes.
So, and I agree with you. I think that with the broadband light done as the first step, and then doing a full field resurfacing in the peri-oral area, and then the rest of the face with that aggressive halo is going to produce this kind of really excellent result. But the longest downtime is going to be contributed by the peri-oral full field. And when patients don't want that, I will do an aggressive halo in that area.
Right. And you know what's interesting, sometimes what I'll do is, if I'm combining halo and deep resurfacing, I'll first do a first pass of just 1470, and then I'll sort of combine micropeels and deeper resurfacing. So basically the teaching point of this is that with the platform, you have a lot of options and you can kind of turn on different technologies or use different technologies to achieve different results, but there's always at the risk of a little more downtime if you get a little more aggressive.
And I would add that with this aggressive halo, you're going to expect a certain amount of post-residual erythema, especially if you go more aggressive in the peri-oral area or periocular area. So that's where I find at 2 weeks, having these patients, when they're fully healed from the halo, to do the BBL treatment. And that really resolves redness. Those, in my experience, this kind of patient is thrilled at about 2 to 3 weeks after treatment when you add BBL about 2 weeks later.
What kind of parameters? Because that's a great concept that I never have done before. So what kind of settings would you use on that sort of touch-up BBL at 2 weeks?
Well, because your settings with the halo have cleared most of the pigmentation and made the surface of the skin a lot clearer, the settings that what you're going to be left with is going to be some degree of red. And the settings that would work best for her at 2 weeks would be the 560 filter, 15 joules, 15 milliseconds, 15 degrees centigrade with the 15 millimeter square, and you do 2 passes over that, or you could do full face with that particular setting. It begins to resolve any redness left from the laser, whether it's full field laser or an aggressive halo, within usually 7 days. Now, these patients become very happy very quickly after doing a BBL after their laser treatments.
Perfect. All right, let's see the next case.
So this is my patient for you. She's in her mid-50s. Her main concern is hyperpigmentation, which she's had for about a 10-year period of time. Gotten progressively worse over time. She's tried topicals, but hasn't really done anything more than that.
Right. I mean, to me, one of the beauties of the Halo system and the Sciton system is that we can now treat Asian patients and get excellent results with a lower risk of PIH. I would do a halo on her, and the key is you kept your density low on this patient. 300, 325. I started at 10% density for 1470, and I would have done the same thing. I might have even taken the erbium down to probably 20 microns at 10%. My question is, based on this, would you use a BBL at the same time as your halo, or would you stage them? And one thing is I want you to teach me about is the tranexamic acid, because in the derm world that's very popular, in the plastic surgery world, we're still kind of dipping our toe in that water.
You brought up some very important points. One is counseling this patient on realistic expectations. 2 is the concerns about post-inflammatory hyperpigmentation or worsening the melasma. The factors that seem to contribute to the darkening after a procedure of melasma is an aggressive BBL treatment or an aggressive laser treatment. So the beauty with the halo...
So too much is going to make you more PIH.
Exactly. So the beauty with the halo is that we can really dial it to a very mild treatment where recovery is 2 or 3 days, very little in the way of downtime, and very little risk of post-inflammatory hyperpigmentation or worsening the melasma. Now, the addition of the broadband light, you asked an important question. Whereas most things that we're rejuvenating, if we're doing the halo, adding BBL at the same time enhances the result. But in the case of melasma, and this woman has melasma plus blotchy pigmentation, in the case of melasma, if you combine the two, BBL and halo at the same time, I think it increases the risk of darkening.
Too much heat.
So I separate them out. I'll do a mild halo treatment, and then I'll follow that 3 weeks later with a mild BBL treatment.
Now, is that for any melasma patient or because she's a skin type 4?
So I'll do that for any patient with melasma. Where I'm in Silicon Valley, we see a lot of ethnic, Hispanic, Asian, and Middle Eastern patients where melasma is what they have. So my go-to treatment for that has been halo. Mild halo, I counsel the patient on the importance.
And get specific on this. You said mild halo. What would your settings be?
So for me, mild is the 1470. For pigment, 300, 325 microns, but 10%. And it won't exceed 10%. And the erbium, I'll keep at 10%. I think the risk of post-inflammatory hyperpigmentation goes up when you go more aggressive with the erbium. So I'll keep that at 10%. I feel really comfortable with both at 10%. And now the reason for doing the BBL was that a lot of people, and this patient is one of them, has erythema as part of their melasma. And you can check that by taking your thumb and rolling it over the cheek, and you'll be able to blanch out part of the darkness that she has on her cheek. That's vascular. And the BBL, the halo won't address that very well with those particular settings, but the BBL will. And so if you do a mild BBL treatment and you keep people on their topical regimen and do a mild BBL treatment.
The settings that you have listed here?
That's not particularly mild, but it's done 3 weeks later.
Got it.
with the Zimmer chiller, you really are able to improve the vascular. And that's how we got this result. We did 3 treatments that way on her, spaced about 2 months apart.
So we started using the VivoSite on some of the melasma patients, and there's definitely a lot of redness. And when we looked at the redness, it's sitting pretty much deep to about 350 microns. So it makes sense that a superficial halo treatment with 1470 in that 300 to 350 range is not going to hit the vessels because they're a little deeper than that. So we found that when we turned the halo up a bit and went deeper, we killed some of the vessels. But the problem is tricky because the spot size gets bigger. You need to kind of separate, you need to increase your density a bit, and then you're kind of getting into that, hey, am I going to cause PIH on this patient? So I think what you did in this patient was very smart and simple, where you kept your settings relatively low and spaced them out, and you got an amazing result on this patient. But I think we've all learned this. Density is low because the way to treat this patient is a bunch of small steps forward. The minute you get too aggressive, you're back to square one.
2 important points related to what you're talking about, Jason. One is the essential need for topical, and you have to maintain the patient on the right topical. Her before photo is actually after 6 weeks of topical therapy, so it's not before starting the topical therapy. And then she maintained that. The tranexamic acid I've been adding to the hydroquinone, tretinoin, and kojic acid formula that many of us are familiar and have used for melasma. I think it may add an additional benefit there.
What about the oral
reducing
form of that? Because I've been hearing a lot at the meetings about oral tranexamic acid.
Most of the work has been done with oral tranexamic acid out of Asia. I don't do that. I've been more comfortable with the topical.
Let's go to the next one. All right, so this is like, these are my favorite kind of cases, okay? I mean, this is my Florida patient that we see all the time. Somebody comes in and they have terrible peri-oral lines and they're just really beat up. Your typical skin type 2 or 3 who's really photo damaged. So, I mean, this is where we live on opposite sides of the country. You probably don't see quite as many as these really burnt to the crisp patients that we see. So what would you do?
Well, this particular patient depends on what her expectations are.
She wants the best result possible and she has unlimited downtime.
Okay, so she's a patient coming in really with high expectation and desire of wanting to really greatly lessen lines. In particular, those that she's got in the peri-oral area. And there really, in my experience, is nothing better than what you can do with Sciton's Erbium YAG platform. I have found with patients where the rest of the face may look fairly good, can do a much milder resurfacing, and then focusing the more aggressive part of the resurfacing with the Erbium YAG in the peri-oral and periocular areas. That makes the treatment recovery easier for patients. I've also found that in all of these patients, adding broadband light either at the time that you do the treatment and subsequent with a full field resurfacing. I usually recommend waiting at least 2 weeks, sometimes 3 weeks, depending on how much redness they have, but doing the broadband light treatment at about 2 to 3 weeks after the resurfacing, and then repeating that 2 or 3 weeks later. Usually 2 or 3 BBL treatments post resurfacing really lessens any erythema that they may have, especially when you go with the kind of settings where you may do 6 passes of 100 microns in the peri-oral area. That's going to stay red for a while. And the BBL, within 7 days of doing a BBL treatment, the redness is dramatically less.
It makes sense. Go back to what we looked at on the previous patient. So if I VivoSighted this patient and really looked at her vessels, they're probably sitting 350, 400 microns down. And if you look at the maximal depth I did on her cheeks, I was maybe at 250 microns. So I was nowhere near the blood vessels. And actually, if I thinned her out a little bit, that might even make those blood vessels more prominent. So I always noticed after deep resurfacing, I cleaned up their skin, but I probably left a lot of redness behind because when you get rid of the photo damage, it exposes the vascular stuff that's underneath it.
And a natural part of the healing process for skin after injury is increasing circulation to the area. So these patients traditionally have really struggled with persistent erythema with CO2 resurfacing, much less with the Erbium YAG. I know you find that in your experience. But because we got a platform that includes Sciton's broadband light, it's perfect to do that post-resurfacing. And I recommend that for everybody.
And it's funny that you mentioned CO2 because I was going to mention this. So back in the old days of CO2, when we had basically one patient came in like this, you would use one setting on the whole face. So what we've learned with the Sciton platform is you can mix and match settings and technologies based upon the amount of damage they have in certain areas. Now, if you look at the settings that I used on this patient, I was a little lighter on her forehead. I really went deeper around her eyes and around her mouth, but she didn't need that deep settings in different areas. So you have a patient who's really photo damaged and lines around the mouth, but the cheeks look pretty good. Use a lighter setting. You're not obligated to use the same setting. As with Halo, you don't have to use the same settings on the whole face. You can mix and match by just hitting different parameters on your screen. So that's what I love about the Sciton system. It's like cooking, you know, a little salt, a little of this, but you see a patient, you read their skin, and you don't follow an exact protocol per patient. You kind of read how the laser is working, and you look at them beforehand and as you're treating them, and you can adjust parameters as necessary.
It's one of the beauties really of how Sciton has given us a fully tunable system with the erbium YAG to really allow us to be able to, I think, fine-tune the art of resurfacing. And as you've done in this particular patient so well, really, you know, and you've taught us so much in terms of, you know, knowing what kind of settings are appropriate in what parts of the face. I also love the spot erbium as well with the Sciton, because then it can focus on seborrheic keratoses that you know, you can take away, or sebaceous hyperplasias, or actinic keratoses. And even if you do a mild full field resurfacing or use the halo, you then can take the erbium with the spot and address areas, and that really gives us a tool that has so much flexibility to really be able to get these kind of results that you have for this particular patient.
You know, it's interesting. A lot of times I'll start with a 2mm spot. First thing I'll do is put the 2mm spot on, and then I'll take down some of the deeper, some of the raised lesions, some of the darker spots. I'll get rid of them first, and then I'll resurface over them. As a matter of fact, I had a little brown spot somewhere on my face, and I had to take it off. I can't find it now. I wanted to point it out and say, look how good it looks, but I don't know where it is.
Tell us what kind of settings that you like to use with the 2mm spot.
I'm pretty much spot on with this. If it's not raised, I'll use with the 2mm spot, 10 microns, 20 hertz. If it's raised and I need to take it down a little bit, then I'll go to 20 microns at 20 hertz. And I'm pretty stuck in those two things. And if they're awake and they just have a spot, I don't inject, I don't use topical, I just use the Zimmer chiller for comfort. If it's part of a deeper resurfacing, then we block the patient. We rarely do these patients under general anesthesia these days. Almost all of these patients are done under nerve block with a little bit of Pronox.
One of the things that I've really appreciated and loved about the spot treatment and the technique that you're describing is that it can be done with topical anesthetic in most cases when you're taking down a seborrheic keratosis or even treating actinic keratoses, even if you're going to 100 microns or so. And I love the fact that it heals, and even though there may be some post-healing erythema after it's healed from the laser, which you can easily resolve with a broadband light, when it ultimately resolves, it doesn't leave a mark. And it's what I love, and you can't even accomplish that really with cryotherapy.
It's amazing. I basically put my loops on, erase this little spot, and you're good to go, and it heals in a couple of days.
Now, this is neck that where the issues are aging neck. 63-year-old neck that has just begun to show signs of aging, both in the quality of the skin and in the neck muscle bands. So tell me how you'd approach this neck.
I do a lot of facelifts. And when 60-something-year-old lady, man comes in with some banding and some crappy skin on their neck, generally, if the skin is loose, they need a facelift. But what I've always said is that a facelift doesn't address the inherent problem of that loose, let's just call it crappy skin. That's a new medical term I created. You know, facelift doesn't fix crappy skin. It pulls crappy skin, and it does look better, but you tend to recur a bit because your skin is not of great quality.
Now, in this particular patient, the interest was really making the neck look more youthful and without downtime. Now, there are a number of other options that we have with Sciton's platform, but for a purely non-invasive, no downtime treatment, it was a combination of BBL. The settings that I like depends on how much redness and how much pigment is present in the skin. And as you pointed out, really aging skin that isn't going to, the quality of that aging skin isn't going to look better with a surgical procedure. So this was a combination of broadband light with a 560 filter, 8 joules, 10 millisecond pulsation and 15 degrees centigrade with a large spot size. So multiple passes with that, followed by broadband light with the settings I like for redness, which is the 560 with 15 joules, 15 milliseconds, 15 degrees centigrade with the square. And then that was followed by skin tight. And then in addition, the platysmal bands in the central anterior neck were treated with a small amount of the neurotoxin, 20 units.
You got a great result on the bands. I find those bands tough. Sometimes they respond really well, and sometimes no matter how much toxin I put on, I just cannot get rid of those bands.
It's a good point because just Botox, let's say by itself with the toxin, it's going to be limited in what it will do, and it certainly doesn't really address the quality of the skin at all. But broadband light plus the BBL skin tight, after you've relaxed those bands or in combination, because you can do the neurotoxin at the same time that you're doing your BBL treatment. And at about a week, you see both the quality of the skin, week to week and a half, the quality of the skin looking better, and then the neurotoxin relaxing the bands. So people see a noticeable difference. The caveats are this. One is skin tight, which is easy to do and painless to do for the patient, doesn't last indefinitely. So this is a result that'll be about a 3 to 4 month result. Now the quality of the skin is improved with the BBL, and that will continue to get progressively better. So a patient like this is going to needs to be informed that we can maintain these kind of results with regular treatments. And those regular treatments would be at 3-month intervals.
So 4 times a year?
Mm-hmm, 4 times a year.
So let me ask you another question. Let's say this patient comes in and she says, I want a facelift, and I plan on doing a facelift on her. That's not going to fix the skin quality. So would you do your BBL treatments before the facelift, or would you wait until the facelift was complete to try to enhance the result?
Well, I think that for a plastic surgeon and for a plastic surgery practice, having Sciton's platform is a no-brainer home run. And you have a couple different options that you can go with. Patients who might not be ready yet to do their surgical procedure, those are the patients that you could benefit by pre-treating them with broadband light. And they're going to love what you or your staff is doing for them with the BBL, trust you that much more, and have better quality skin on top of all of it, so that when they're ready to do that surgical procedure, the end result that they'll be that much more thrilled and that much more trusting of you and your practice. If they're ready to do surgery right away and they want to sign up and they want to be on your schedule in a week, really you're not going to be doing the BBL until post-treatment. And in that particular case, for you as a surgeon, you may decide that where you feel really comfortable beginning to do BBL and BBL with skin tight would be at about a 2 to 4 week period of time post-operatively.
And
swelling has
occasionally,
gone down a bit.
And the thing is also, I want you to delve on this a little bit. Occasionally when we do a facelift, there might be a little bit of bruising in some areas. So if they come in with a little bit of bruising, would you address that with BBL to enhance, to kind of quicken the resolution of the bruising?
Well, you bring up a really good point, and BBL is really effective at an early bruise. So in the cases when it's a non-surgical situation,
filler, like I put a filler in,
and
I
you've
get
got
a
a
little
needle-based bruise or something that's produced a bruise or discoloration, BBL can be done the very next day. Post-surgery,
what would your settings be? Let's go there. I did some Botox on my eye and I got a nice bruise. What do I do?
For skin types 1, 2, and 3, the settings that I like for post-injection bruising, and I'll do that the very next day, so it could be 12 to 24 hours later, is the 560 filter, 15 joules, 15 milliseconds, 15 degrees centigrade, and I like that with the 11 millimeter circle, and I'll do 1 to 2 passes over the bruise. The darker the bruise, the generally more conservative you need to be with the
careful.
parameter.
There's a lot of chromophores, so you have to be careful.
In the case of surgery, where they may have, you see them the 1 day post-op and they've got a certain amount of swelling and a certain amount of bruising, I would leave that up to the surgeon to decide whether you want to do BBL, because there may be a fair amount of chromophore from
I'd probably wait
extravasated
at least
blood.
a couple of days to do that. But if there was, usually our facelifts don't get really bruised these days, but there could be a couple little spots that I might treat. I would say maybe like a week later or so. Is there anything left?
What I would suggest is skin tight. Now, skin tight because it's got very little risk in terms of overheating a bruise, and skin tight, in my experience now, reduces swelling. So in the cases where I found that to be really beneficial post-liposuction and also post the deoxycholate treatments in a neck where people are going to get a certain amount of swelling with that treatment.
Filter?
So I like the 590 skin tight filter.
For skin types 1 through 3?
Actually for all skin types, up to 5. 6 I'll use the ST 800 skin tight filter. But we've found that post kybella swelling in the submental area or the submandibular area, the very next day doing skin tight dramatically and it almost in front of your eyes reduces the swelling and the discomfort. So I think that there's great potential for a surgeon like yourself to incorporate a gentle skin tight treatment, 2 to 4 minutes on each cheek the day or two after surgery.
Wow, I got a lot of tips today. Thank you, Patrick.
Bruising reduces as well. It's interesting how bruising and swelling are reduced just by skin tight.
And that's not even high peak powers. That's sort of a lower power multiple pass technique. So that's
correct.
amazing that it does
In that particular case, we're not even worried about getting to 40, 41 degrees. Just warming it up with that red and infrared light the day after surgery.
But it increases blood flow, obviously.
It does, and it reduces inflammation and inflammatory factors. Makes it and reduces pain.
Click the subscribe button to ensure that you never miss an episode of LaserChat. In the next episode, Doctors A.J. Burns and Jill Weibel get specific on treating complex conditions in 4 patients using a combination of laser, surgical, and non-surgical techniques. Learn how these experienced surgeons achieve stunning improvements in atrophic acne scars, hypertrophic and hyperpigmented breast lift and plastic surgery scars, moderate to deep periocular and peri-oral wrinkles, and laxity in the upper, mid, and lower face.